Thank you, Arubda. The heart failure is a relentlessly progressive neurohumoral syndrome based in cardiovascular system with survival worse than most cancers. Hemodynamic definition of heart failure or heart failure with reduced ejection fraction is when the ejection fraction is 40% or less with structural change and filling pressures are elevated and there is a demand-related reduced cardiac output. So that's the hemodynamic definition of heart failure with reduced ejection fraction. The population of this country is about 1400 million. That is the estimate given about 7 months back by Government of India. We do believe that we have 200 million people who are at risk of developing heart failure either as a result of diabetes, hypertension, or coronary artery disease. Pre-heart failure, where there is evidence of structural involvement already, is 50 million. 10 million people have clinical heart failure, and about 1 million people have advanced heart failure already. This is the least probable estimate. Probably the numbers are higher than this. The important thing I want to say about HFrEF is the HFrEF is a biologically active and dynamic process. It doesn't remain static. It doesn't remain static with regard to volumes and ejection fraction or filling pressures or for that matter, the left atrial function. So and it can improve, it can deteriorate, it can go in remission with or without therapy. So the typical investigative framework after clinical evaluation and ECG is biochemical, imaging, and hemodynamic assessment. And ECHO helps in the two parameters, that is imaging and hemodynamic assessment. And as the previous discussion was going on, first thing is ECHO defines the phenotype of heart failure. I'm so sorry, something is wrong. I don't know where we are going. Is somebody else's talk here? Absolutely not clear what happened. Anyhow. So as I said, the ECHO defines the phenotypes of heart failure. So we have 4 different phenotypes. The 2 types in the middle actually can go on either side and can come from the either side. But nevertheless, in this country, whatever epidemiologic data is available, at least 70% of the heart failure is heart failure with the reduced ejection fraction. With regard to etiology, more than half of the patients in this country are because of ischemic heart disease. The rest have multiple causes: genetic, inflammatory, infiltrative, metabolic, nutritional, endocrine, parasitic, and autoimmune. So far, what I have said is that HFrEF is a clinical syndrome of effort intolerance. There are structural alterations in the heart, there are functional alterations in the heart, ejection fraction less than 40%. There are elevated filling pressures at rest or stress, and objective evidence of systemic or pulmonary congestion. Where does ECHO come in? ECHO helps in structural characterization, functional characterization and phenotyping, hemodynamic characterization, and to some extent tissue characterization. Tissue characterization is done far better by cardiac MR, but ECHO also helps. So how do we use ECHO and HFrEF in clinical practice? Both for diagnosis purpose, for finding etiology in some of them, prognosis, treatment, for follow-up, for device management, viability studies, especially if revascularization or no revascularization plan, and of course for reverse remodeling. Hemodynamic phenotypes of HFrEF are 2. There are patients who have heart failure with reduced ejection fraction and normal resting filling pressures. These individuals have good prognosis. And HFrEF patients with elevated resting filling pressures, patients who have relatively bad prognosis. Since the cornerstone of heart failure is elevated filling pressures, when filling pressures elevate, these enlarge the left atrium, change the flow in mitral valve and pulmonary veins, raise pulmonary artery pressures, and cause pulmonary congestion. So these are the signs you would see in most patients with heart failure. Atria would be enlarged, mitral flow would tell you whether the filling pressure elevated or not. pulmonary artery pressure get elevated, and of course you have lung congestion in the form of B lines which can be picked up by echocardiography. So this is how actually the evolution from a normal heart or a normal left ventricle becomes a HFrEF. So you get ejection fraction which is lower, volumes which get increased, mass which gets increased, more sphericity and dilated annuli and mitral regurgitation, along with, of course, filling pressures. Etiology, mostly you don't get idea about etiology. I will not say mostly, in a significant number of patients, but sometimes you get idea. And Dr. Anuruddh, they presented the typical case like this yesterday. This is, of course, there is no brainer actually. This is what is cardiac sarcoidosis. So you know the etiology of this HFrEF in this particular patient. Similarly, that is also no brainer that this is an ischemic etiology. This is a patient who has anterior valve myocardial infarction as well as old inferior valve myocardial infarction. You can see the bright scars. And these are subendocardial scars, so we know that this patient has most likely ischemic etiology of HFrEF. And of course, sometimes the genetic variety of cardiomyopathies can be detected. For example, a classic example of a non-compaction of the left ventricle in this child. So we know that we do get etiologic information from HFrEF. What kind of minimal information from echo are we looking at? We need idea about ejection fraction, volumes, mass, sphericity. We need idea about segmental wall motion abnormality, scar, aneurysm, thrombi, left atrial volume, degree of functional mitral regurgitation, PA pressures, RV function, E to E prime, global longitudinal strain, RV free wall strain, and LA reservoir strain. These are the minimum information which we need to have every patient of heart failure with reduced ejection fraction by echocardiography. So having given you a preamble, let us quickly see a case of HFrEF and go through. This is a 34-year male who has typical symptoms of heart failure. He is diabetic and he also has some hypertension and of course some renal dysfunction. As you can see, the X-ray shows you cardiomegaly, the ECG shows you T-wave changes. Here is the echo of this individual, global hypokinesis, enlarged left ventricle, enlarged left atrium, pericardial effusion, moderate mitral regurgitation, and ejection fraction of 22%. The ejection fraction definitely defines the prognosis. This person had 22% ejection fraction, and we know that lower is the ejection fraction, greater are the major adverse cardiac events. The other thing which we of course have to keep in mind is the patient has moderate mitral regurgitation, and as the degree of mitral regurgitation increases, the prognosis gets worse in patient HFrEF. So not only you have to detect mitral regurgitation, you have to quantify mitral regurgitation. The filling pressures are another important thing. In this particular individual, the filling pressure, the E to E prime ratio is 24. Why is it needed? Because large data from Mayo Clinic shows that once the E to E prime crosses the magic threshold of 15, the mortality keeps going up. And as it drops below 15, with or without therapy, the mortality goes down. The B lines are another important thing in every patient HFrEF in the lung, which you should see. Here are the comet lines. More are the B lines, worse is the prognosis of heart failure, more so in heart failure with reduced ejection fraction. You need to look at the tricuspid regurgitation. This particular boy, a young man, 34 years, has a TR velocity of 30.2 meters, indicating an estimated PS systolic pressure of 51. And RV function probably is also decreased because tricuspid valve S prime is 8 centimeters per second. I remember the TR velocity is prognostic, and this again large data shows once the tricuspid gradient because of TR crosses a limit of 35 millimeter mercury, prognosis becomes worse in patients of heart failure. We need evidence of, we need data about right ventricle function HFrEF. We know that the right ventricle function decides the prognosis. Here is some data in dilated cardiomyopathy and ischemic cardiomyopathy, both showing people who have high pulmonary artery pressure, low ejection fraction, have worse prognosis. Mortality actually in patients who have right ventricle dysfunction 3 times more compared to those who have normal right ventricle function. And of course, you have to look at global longitudinal strain. I talked yesterday a lot about that. This patient has a 9% global longitudinal strain, and global longitudinal strain definitely dictates mortality. Lower is in numerical terms, lower is the global longitudinal strain, the higher is the mortality. We of course know that not only that, it predicts also the occurrence of HFrEF. Lower is the global longitudinal strain, more are the chances of developing HFrEF. So our patient also has a RV free wall strain of 13% and RV global strain of -7.8, indicating our patient has biventricular dysfunction. And as we already said, the 2D strain of less than 21% indicates bad prognosis, and our patient has 13.8. We also have data to suggest that the RV GLS actually dictates prognosis in heart failure. The LA strain also dictates the prognosis of HFrEF patients, and the peak atrial longitudinal strain, as it goes down, the prognosis becomes worse. Not only that, of course, a HFrEF patient, the potential sources of complications can be found out by echo, as in this individual with left ventricle thrombus. Now, so having said that, what more we can get information from echo? Echo tells you, as I said, HFrEF is a dynamic and active process. You can tell about progression, recovery, and remission. Now with the newer drugs like ARNI, remission and recovery is possible. So look at our patient. Our patient had this, the inferior vena cava was dilated actually in 2016, and of course it collapsed in 2017. I don't know why the pictures are not moving, but nevertheless we will go ahead. The ejection fraction actually improved from 22 to 58% over a period of time. Mitral regurgitation practically disappeared over 2 years, and of course the global longitudinal strain improved from 9 to 17% with treatment in this particular individual. So this index patient showed value of echo in diagnosis of HFrEF, etiology, prognosis, and reverse remodeling. We could actually characterize the tissue better with cardiac MRI, but of course echo did give us a reasonable idea, and presumed etiology was non-ischemic. So to summarize, ladies and gentlemen, echo and HFrEF provides the syndromic diagnosis. It provides an idea about etiology. It could be ischemic heart disease, valvular heart disease, congenital heart disease, and of course constrictive pericarditism. Phenotyping of heart failure helps in guiding therapy, and it helps us in deciding the prognosis, remission, remodeling. And our case typically showed you remission and of course significant remodeling, and we can identify the source of potential complications. Thank you very much.
Thank you, Dr. Mohan, for a erudite speech. Please sit over here. We'll be taking up the discussion part after the other speaker has spoken to save some time.
So our next speaker is Dr. Debashish Ghosh. He will manage HFrEF.
And avoid inertia also.